We are live now.
Good evening, everyone. Today, we have this Metacrinology webinar, where this is the lipocrinology part 2. The basic motto is adipose tissue and metabolic syndrome. And today, we'll have a case discussion or case presentation, and also some MCQs. Then we'll discuss adiposopathy in cardiometabolic syndrome. And again, we'll discuss approach to particularly specifically childhood obesity. So when we are talking about adiposopathy, it is not the presence of adipose tissue. It is not the presence of good cholesterol or bad cholesterol. And again, in last few years, there is a concept like we are discussing about metabolically healthy obesity or metabolically bad obesity. So adiposopathy is, in a way, it is the bad fat which is there, and majority time it is actually endocrinologically it is being governed. That means there are a lot of hormones, there are a lot of autocrine factors, paracrine factors which play a critical role specifically in adiposopathy point of view. And regarding childhood obesity, we know throughout the world, obesity is now, or you can say malnutrition is the biggest problem, and among the malnutrition, probably obesity is much more prevalent than the undernutrition point of view. And again, from the obesity point of view, in the childhood or in the pediatric age, it is significant throughout the world, and that is quite significant among the developed countries, and again that is quite significant in the developing countries also. So what is the reason? The reason is actually nowadays you will see we have like a lot of fast foods throughout everywhere. We have actually westernized our food, lot of fast foods are there. Again, we have changed our habit. You will see any child, no physical activities, no outdoor activities. Everybody try to watch movies, try to watch, do video games. Again, they try to take food while watching TV. These are certain things, or these are certain behaviors which putting or increasing the risk of childhood obesity. And with this, or to discuss, we have with us our chairperson, Dr. Roopa Mehta. And she's research head of Metabolic Disease Research Unit of Department of Endocrinology and Medical Sciences with Nutrition in Salvador, Jubin, Mexico. She is associate professor in both pre and postgraduate endocrine programs. She is a principal investigator for phase 3 clinical trials. She is having a lot of interest, clinical interest, with particularly type 2 diabetic patients, metabolic syndrome, and lipid metabolism disorders. She has presented at ADA and ESD conferences and also AS meetings, and presented her research posters in national and international meetings. She is associate editor for diabetic medicine, an advisory board member and reviewer for diabetic therapies. And she has received Alfonso Rivera Research Award and the Young Investigator Award from S. She has authored and co-authored publications in international journals in addition to numerous book chapters. Again, the co-editor of a book for patients living with diabetes, a practical manual. With that much introduction, I'm handing over the whole session to Dr. Roopa Mehta. Over to Dr. Roopa Mehta, ma'am, please.
Hello, everyone. It's a real honor to take part in this Metacrinology webinar. And as Dr. Abe has already mentioned, the theme is adipose tissue and the metabolic syndrome. And we have three great speakers that will talk through case histories, we'll go through adiposity and the cardiometabolic syndrome, and go through the approach to childhood obesity as well. So let me introduce you to them. So we have Dr. Mohan Shenoy. This will just be a brief introduction. I don't want to eat up the time for their talk. So he's assistant professor in the Department of Endocrinology in the Sri Gokula Medical College in Trivandrum. He has an extensive CV, as you can see, with research experience and special interest in insulin resistance and pediatric endocrinology. He has as well presented and published several papers in national and international journals. The next presenter, please. Can we have the next slide, Sanjay?
Yeah, next slide.
We have Dr. Arun Kumar Singh. He's a senior consultant endocrinologist in Sarvodaya Hospital and Research Center in Faridabad in Delhi. And his major achievements have been an award for best research paper and also an award for best research paper in Endo Update in 2016. He has also published extensively in national and international journals. And our next presenter is Dr. Ipsita Mishra. She's a consultant diabetologist and endocrinologist in Cuttack, Odisha. She's an associate professor in the Department of Endocrinology in the SCB Medical College in Cuttack. She has also presented in various meetings her own research and has published in various national and international journals. She participates in public awareness programs for diabetes and has received various awards and honors. So welcome you all. I will pass now on to Dr. Mohan, so he can now start his presentation.
No, yeah. Before,
Mohan,
just 1 minute, ma'am. Before starting one session, so I request all my audience, all my friends, and including everybody, that there is a polling. That means Mohan will present some questions, and everybody has to answer all questions. And at the end, we'll definitely discuss all the question answers. And again, we'll discuss about the winners. There will be 3 people who will get the first and second and third. People will definitely get the benefits of that. And again, we'll discuss each and every questions and answers, and Mohan will discuss that part in the latter part of the session. So over to Mohan, please.
Good evening, everybody. Am I audible?
Yeah.
Yes. Thank you, sir, for the kind introduction. I thank Dr. Kalra, sir, and Dr. Gagan Priya for giving me the great opportunity. And thank you, Chairperson, for giving me this time to present the case. So the agenda is, as sir told, the case presentation. So coming to the case 1, this is a 45-year-old male. He's a businessman, and being a busy man, he is actually taking care less of his health, more of his economy. And he has gained weight 14 kg over the last 3 years. And his BMI, as you can see, the weight is 75, the height is 172. So the body mass index is 25, and not obese, but the main point is he has gained weight recently. So the waist hip ratio in this patient is brought to me was 0.94, which is fair enough. And you can see also the blood pressure, which is 140 over 90 millimeter of mercury. So in relevant point in his history, his family history, there is a strong history of diabetes in both the parents and obesity in multiple relatives. He also on probing mentioned that he's having coronary heart disease in the maternal uncle. So significant lab results for the metabolic outcome was checked. So briefly, I'm just highlighting the main results. The fasting plasma glucose was 110. Mind you, he was not having any diabetes before. So also you can see that postprandial glucose is also touching the limit, that is 140. And these are just the border of the normal. So thyroid function test, the thyroid TSH is normal, 3 MIU by liter. HbA1c, which is the marker of glycemic control, it is coming to 6.9%. Uric acid is also 6 milligram per liter. And you can see that fasting plasma profile, lipid profile, the total cholesterol is 230. It is grossly deranged. So triglyceride is 225. The high density cholesterol is 29. And you can see that the LDL, low density, is 156. So this is only a brief outlook for the first case. And as I will just prelude to the first speaker. So the main concern in this patient is with strong history of diabetes and family history of heart disease, he's having the risk for all the consequences of metabolic syndrome. Insulin resistance marker is also high. And regarding this questions, so he's having the ultrasound also done showing fatty liver. So he's having grade 2 fatty liver. So we have to evaluate the etiology for the insulin resistance, and we have to delve into the reasons why NAFLD, that is non-alcoholic, is also non-alcoholic. So for this patient having the problem of uric acid, so is it significant for this country? And also on relevance of adiposity cutoffs in South Asian population. So next case, briefly, it's a female, 28-year-old female, a software engineer, married for last 2 years and planning to conceive. But definitely you can see that she has gained weight like the first patient over 3 years, gradually around 14 kg. The point to note is that she is having irregular cycles for the last 1 year. And she is brought to us for the evaluation of infertility as well as for evaluation of obesity. So she's not that obese, but you can see that for the height and weight, the BMI, the waist-hip ratio is coming to 1.2, which is significant. So blood pressure is 120/80. She has also clue towards the metabolic profile. You can see acne is there, and she's also having grade 2 acanthosis nigricans, which is a marker of insulin resistance. So for them, we do the hirsutism staging. So it's coming to modified FG score of 10. So other markers of other secondary causes, there is no goiter, there is no striae or proximal muscle weakness. So in a nutshell, the relevant points in history also has been mentioned. She's had regular cycles till date, till the last 1 year. That recently only she developed irregular cycles. And to complete the lab test, the fasting glucose is normal, that is 100. And you can see the postprandial glucose is 130. And other profile, significantly, as you can see again, the uric acid is coming to 6 milligram per liter. She's a pre-diabetic, having HbA1c of 6.2 and having borderline prolactin elevation, that is 24 units. The fasting blood lipid profile shows the total cholesterol of 180, triglycerides of 150. HDL for that age and for that sex is actually a bit low, should be more than 50, so it's having 45. So the questions in this patient to be answered in the future discussions would be, is there a PCOS metabolic overlap, as this patient showed the indicators of overlap? And regarding the obesity classification for Edmondson staging, how far it is important in our population subset? And when the concern is that patient gains further weight, whether you consider bariatric surgery when BMI crosses the limit of 30 or 35. And as Dr. Abhay Sahu sir has mentioned, the issues regarding metabolically healthy phenotype and whether obesity paradox is a real concept to be worried upon. So I'll stop the share screening and I will just give the stage back to the moderator. Dr. Roopa?
Yeah, now we can start with Dr. Arun. Can you now share your presentation? And then we'll come back to you, Dr. Mohan, for the remaining 2 cases.
Sure.
Very good evening, everyone. Thanks to the organizers, thanks to the chairperson. So I'm going to discuss about adiposopathy. So that is relatively newer concept, and it's linked with the cardiometabolic syndrome. So I would be discussing under these subheadings the understanding of obesity and its link between metabolic syndrome and the outcomes, and what is the differences in concepts of obesity, adiposity, and adiposopathy. and how does the adipose sites plays a role as endocrine organ, and the active role of adipose sites in causing systemic inflammation and increased risk of CVD risk factors and adverse outcomes, and what the therapeutic options we have right now, and what is there in the pipeline, and summary. So in the interest of time, I'm not going to discuss about the epidemiology or statistics or the burden of this problem. I will be just discussing about the understanding the pathogenic mechanisms, and what do we have in pipeline, and what is there to be more need to be explored about the adiposity and adiposopathy. So to begin with, I would start with the definition of obesity. We all know about the most widely or commonly used definition of obesity is based on BMI. We all know this is WHO classification, and based on body mass index. So there's nothing but simply body weight adjusted for height actually. So definitely it has inherent problem that it does not consider the age, race, body composition. So there are limitations, but still, because it's very simple to calculate BMI, so it is most commonly used tool to define the obesity. The other commonly used parameters are waist circumference or waist to hip ratio, which Dr. Mohan rightly pointed out in his cases which he presented. So these are the cutoffs for to define obesity: waist circumference for men more than 102 centimeter, for women 88 centimeter. But the cutoffs are both the BMI cutoffs and the waist circumference cutoffs are lower for the Asian population. So why we are talking about obesity or adiposity? Because it has been observed that the obesity or high body weight is directly linked to the number of comorbidities and overall survival as well. So this was a collaborative analysis of more than 50 studies, and it shows the link between BMI and mortality rates at different levels of BMI. So you can see the curve, J-shaped curve actually. So the mortality rates are lower, the higher even at the lowest BMI, and then they are least close to the BMI of close to 22 to 25. And then after that, after 25, the mortality rate increased by approximately 30% for each 5 kg per meter increase in the BMI, and it doubles for each 10 kg extra 10 kg per meter square of BMI. So it is strongly associated with the morbidity and mortality as well. And so in previous study, they just studied the association of BMI with the mortality. This is again large study from the Europe, which analyzed the association between not just BMI, considering its limitations, which I already mentioned. It does not consider the body composition or race or ethnicity. So they analyze the association between BMI, and they also considered waist circumference. So the findings were almost similar for both the things. So you can see the again J-shaped curve, lowest mortality rates close to the BMI of 24, 25, 23. So this is European data. And again, the waist circumference close to the in between 85 to 95, the lowest mortality rates. And as after that, as the waist circumference goes up, or as the BMI goes up, the mortality rates goes up. So there's strong association. So how does obesity causes morbidity or increase death rates? What is the mechanism behind that? So this is because of the clustering of different metabolic disorders with the obesity that has been observed by different investigators worldwide since long time. These are data from, on the left side, this is data for women from the nurses health study, and on the right side, this is data for men from the professionals follow-up study. So you can see clustering of type 2 diabetes, cholelithiasis, hypertension, coronary heart disease. So these are just few of multiple metabolic abnormalities which are seen to be more frequent, or they face with the people with the high body weight or obesity, and clustering clustering of these abnormalities leads to the morbidity and mortality. So because of observations, similar observations worldwide by different investigators, so different organizations came out with the definitions of metabolic syndrome that is very widely accepted concept. It has been very widely accepted and popular till a decade back actually. But then you can see the heterogeneity in different definitions. Yes, most of them include the glucose levels, HDL cholesterol, triglyceride levels, and parameter of obesity, either its waist circumference or its BMI and blood pressure. So they include almost all of them include these 5 components, and 3 or 2 of them define metabolic syndrome. But there are multiple definitions of metabolic syndrome. That is a problem. And so it is just a representative study, not a landmark study. So just to show that these observations of clustering of dyslipidemia, hypertension, and diabetes or impaired fasting glucose or glucose tolerance test with obesity has been similarly observed in India as in other parts of the world. And you can see those almost in this particular study, at least these 30 patients out of those who were included in this study, you can see central obesity, 50% almost on an average, close to 50% patients had central obesity. So similar trend observed in each and every part of the world. So, but then does the BMI or obesity tells the entire story? That is the questions to Dr. Abhay already mentioned about the concept of metabolically unhealthy obese, metabolically healthy obese, metabolically unhealthy normal weight. So those are different interesting terminologies used, but you can see in this particular study, so this is again analysis of 33 studies, more than 1,20,000 patients with the obesity were included, and you can see only 50% of patients where they could be categorized as having metabolic syndrome, and they were considered as metabolically unhealthy obese, and 50% of patients were kind of they were defined metabolically healthy obese. But then again there was heterogeneity, and if you analyze the data, so only 7% of these metabolically healthy obese also, but only 7% of patients did not have any component of metabolic syndrome and normal insulin resistance. More than 90% of patients had actually either one component of metabolic syndrome or increased insulin resistance. It was assessed by HOMA-IR. So that is a kind of misnomer actually. So we should not get carried away by this terminology of metabolically healthy obese. That is, I would say, debatable. So it depends on how the defining criteria are being used. So here it was those people with only 2 or less components of metabolic syndrome. They were not actually truly healthy. Even of this 50%, you can say more than 40% had either insulin resistance and either at least one component of metabolic syndrome. And in long term, it has been seen that a large proportion of these patients do progress to this category of metabolically unhealthy obese actually. So it's not just the obesity or BMI. There are many more things which contribute to the development of CVD risk factors. And so coming to the concept of metabolic syndrome and clustering of metabolic abnormalities with the obesity. So I already said there have been many investigators who tried to come up with a definition of metabolic syndrome and name these syndromes by different terminologies. So, but broadly, these classifications could be divided conceptually into 2 groups. A was the concepts which considers obesity as essential feature of metabolic syndrome, and other group was which did not consider obesity as essential feature of metabolic syndrome. So those were 2 groups, but what is the importance of these 2 groups actually? So the first group gave more importance to the adiposity, obesity or adiposity, actually the body weight, and the second group gave more importance to be maybe the body fat proportion or the adipocyte tissue dysfunction. That was the concept here, because on the right side you can see those who did not consider obesity as essential feature of metabolic syndrome. They believe that people at normal weight, but abnormal fat deposition or abnormal fat function, abnormal adipocyte dysfunction, they are also at risk of developing CVD and developing metabolic abnormalities. The concept of the adiposopathy itself was hidden here. So people can have metabolic abnormalities even at normal BMI, normal weight, because of abnormal distribution of body fat or abnormal function of body fat. And the concept of metabolic syndrome has been challenged a long back by a joint statement from ADA and European Association for Study of Diabetes for multiple of reasons. Mainly 8 points. So I just shared 5 criteria for diagnosis of metabolic syndrome, but then there are many more. So there is no uniformity on the definition. And then even in many definitions, people with frank diabetes are also included. So ideally, metabolic syndrome is a risk marker which identifies people who are at higher risk of developing the diabetes, hypertension, and CVD. But many definitions include people with over type 2 diabetes. There is no concept of unifying etiology. So those were the objection points. No clear basis for including or excluding other CVD risk factors. That was not included in the definition. Again, it should be a risk marker, but I think there is no clear point whether patients with CVD should be included or excluded. Then CVD risk value is variable and dependent on the specific risk factors present. CVD risk associated with the syndrome appears to be no greater than the sum of its parts. That is very true. Then treatment of syndrome is again not different from the treatment of each of the components of metabolic syndrome. And then obviously, because of these issues, the medical value of diagnosing the syndrome is not very clear. The implications of diagnosing the metabolic syndrome is not very clear. So this entity, the terminology has been already challenged and debated. So
Dr.
how
Arun, could you, Dr. Arun,
adiposity? So
Dr. Arun, could you speak a little bit closer to the microphone? Some of the
sure,
listeners.
Sure. So
okay, and we have another 10 minutes left.
Yeah, sure. So there has been a correlation between adiposity, basically the body fat distribution, not just the body fat composition. So interesting study from Japan. So you can see people with similar BMI, men and women, but you can see linear relation with the visceral adipose tissue. So this is visceral adipose tissue, and this is subcutaneous adipose tissue. So you can see the linear relation with the visceral adipose tissue at the same BMI with the CVD risk factor. So it's not the only BMI or the body fat. Actually, is the body fat distribution also which alters the patient's risk. Then again, obesity and adiposopathy, similar trends. So you can see here obese people, both groups are obese, similar BMI, men and women, but you can see the difference in the waist circumference. Actually, the people with the higher waist circumference had higher triglyceride levels and low HDL levels compared to the people with lower waist circumference. So again, that suggests the importance of fat deposition in viscera or central fat deposition that is more pathogenic. Actually, it's not just the body fat composition overall, but the distribution of fat in the periphery and viscera. So how the adiposopathy contributes to the metabolic abnormality. So these are different pathways which are understood to play a role in metabolic abnormalities: excess of adipocyte hypertrophy, then deposition of fat in the visceral adipose tissue, the active adipose tissue in viscera leading to the increased release of free fatty acids, which get deposited into different other viscera and various tissues which are not supposed to store the fat, and then the various hormones, interleukins playing a role, and inflammatory markers and impaired crosstalk between the fat tissue and the different organs. So there's sick, how the visceral obesity leads to the adipocyte dysfunction. So I would say ignore the left side, focus here on the right side. It happens at multiple levels because of lack of subcutaneous fat or dysfunction of subcutaneous fat. The excess of calories cannot be stored in the subcutaneous tissue, and there's impaired clearance, which leads to the ectopic fat deposition in heart, liver, muscle, pancreas, and elsewhere. And this visceral fat is highly metabolically active, that releases multiple cytokines that lead to the systemic metabolic inflammation and insulin resistance, pro-inflammatory state, pro-thrombotic state, and that in turn leads to the increased risk of atherosclerosis and cardiovascular disease actually. So on the left side, it's same thing actually. On the right side, it just shows it's not just the body fat actually. It's how the body fat disposition in different compartments affects the lipid levels and cytokines, leptin and adiponectin, and insulin resistance and vascular failure. Higher the visceral fat, higher the cholesterol levels, lower the levels of leptin and adiponectin, and higher the risk of insulin resistance and vascular failure. So adipose tissue is not inactive tissue, it's active endocrine gland actually, and you can see the number of the, by the way, this is a complete list. It secretes number of proteins and receptors and enzymes and cytokines which play a role in metabolism and systemic inflammation, and that's how it leads to the insulin resistance, endothelial dysfunction, and the risk of atherosclerosis, and it increases the risk of dyslipidemia, hypertension, diabetes, and other adverse outcomes. And so these different adipocyte metabolism is different in these different ectopic sites like abdominal viscera, visceral fat, hepatic fat, muscular fat, fat in the heart or myocardium or epicardial fat, perirenal fat, pancreatic fat, and fat around the neck. These are the common sites of ectopic fat deposition, and the metabolism of the fat tissue is different in each of these different ectopic sites, and that through different mechanisms leads to the atherosclerosis and cardiovascular disease. Some encouraging data from India. So regarding the understanding of adiposopathy. So we all know about the important role of central visceral adipose tissue, but in this study, the Dr. Mathur and his group showed some role of even peripheral subcutaneous adipose tissue in pathophysiology of type 2 diabetes. Basically, it was characterized by adipocyte hypertrophy. The pathologic changes were observed in the peripheral adipose tissue from the thigh, and there was upregulation of inflammation related to pathways. So it's not just the differential distribution of body fat in Asians, South Asians, which puts them at higher risk of ASCVD. Actually, it's also the maybe fat dysfunction which also puts them at higher risk of atherosclerotic disease and metabolic abnormalities at younger age. Coming to the last part of my discussion regarding management. So definitely management depends on the understanding etiology of adiposity and adiposopathy and therapeutic options, and what should we target? Should we target weight, body fat, or sick fat? That is adipocyte dysfunction. What we have been doing till now, so based on the concept of metabolic syndrome, what we are doing in metabolic syndrome, we are actually targeting different components of metabolic syndrome. For obesity, we are trying to address that with the physical exercise, with the lifestyle modification, dietary intervention, and for the metabolic abnormalities, we are just addressing the different abnormalities like LDL cholesterol, triglyceride, blood pressure, and diabetes medicines, anti-diabetic medicines. There is no medical intervention which is directly targeted to the etiology of metabolic syndrome. That needs to be investigated and studied actually. So coming to the treatment of adiposity, next to the metabolic syndrome. So treatment definitely starts with identifying the cause of adiposity, and once you know the exact cause of adiposity or obesity, then interventions can be more targeted. That is very important, reaching to the proper diagnosis, which is responsible for the weight gain or obesity, and then targeting the cause of obesity. But of course, the most common cause of obesity is the imbalance between the energy intake and energy output, energy expenditure. That is called exogenous obesity. Definitely, this is also influenced by multiple other factors like genetic predisposition, but this is the most common cause of obesity. That is imbalance between the energy expenditure and energy intake. This exogenous obesity, we have multiple tools to manage. Obviously, behavior modification is there, and the most commonly used interventions are the diets and physical activity. So there are different popular diets used for weight loss, like low calorie diet, very low calorie diet, a meal replacement, low fat diet, low carbohydrate diet, that is ketogenic diet, very low carb diet, that is ketogenic diet, high protein diet. So multiple popular dietary interventions are there, but over the long run, it has been found they are actually equally effective. None of them is superior to the other in long run. And any of these dietary interventions can be chosen depending on patient's cultural, social background, and patient's preference. All dietary interventions are equally effective. Then other important intervention in the management of obesity actually is the exercise. This is some interesting observation. This was systematic review and meta-analysis on the effects of exercise versus hypocaloric diet. So here you note when comparing the diet versus training, that was exercise, diet caused a larger weight loss, but in contrast, the trend was observed towards a larger visceral adipose tissue decrease with the exercise. So though diet caused larger overall weight loss, but the visceral adipose tissue loss was more seen with the exercise. So definitely we are looking for more visceral adipose tissue, not just body weight loss. And changes in weight and visceral adipose tissue overall showed a strong correlation after diet, but only modest correlation after exercise. That means visceral fat loss was more, predominantly visceral fat loss was seen with exercise, and predominantly subcutaneous fat and overall body fat loss was more seen with the diet. And even in the absence of weight loss, exercise was uh, shown to decrease VAT by 6%. So that is very important to note. Even patients did not have overall weight loss, there was decrease in visceral adipose tissue, while that showed virtually no change. So these are very important observations which reinforce the importance of regular physical activity and exercise. And I think the intervention should not be considered to be failed if there is no weight loss. We should be assessing the impact of interventions for weight loss by the assessment of body fat composition or visceral fat assessment. So after diet and exercise, the pharmacotherapeutic options for overweight and obesity, we have medicines and we have surgical options. So different cutoffs for the Asians, lower cutoff for the Asians. You can see here, diet and physical activity behavior therapy must be offered to all who are overweight, 23 plus or 23 or more kg per meter square. And pharmacotherapy can be offered at the BMI of 27 with the comorbidities, and surgery can be offered to people with BMI as low as 27.5 with serious comorbidities. So these are the cutoffs for the diet, physical activity, pharmacotherapy, and metabolic surgery. So again, problem with the medical treatment is they just consider the effect of treatment on overall weight. They do not consider its differential effect on lean weight loss or body fat loss or loss of visceral tissue. That is the one drawback with this approach. And they do not take into consideration the importance of correction of adiposopathy, that is adipocyte inflammation and adipocyte dysfunction. So those are not considered while using the pharmacotherapy. So coming to interesting case scenario. So just before I said, should be targeting the weight loss or fat loss, or we should be targeting weight or waste actually. So this is just example of one patient who only lost 3 kg after 1 year of intervention with the diet and exercise. The patient lost only 3 kg. So in routine clinic practice, we would declare it as unsuccessful intervention. So that is the limitation right now in clinical practice. But when the waist circumference was measured, not just BMI, so there was no change in BMI of this patient, but waist circumference decreased by 6 centimeters after 1 year, and see the change in visceral fat that decreased by 17.5%. The visceral fat was 271 centimeters square, and after 1 year of intervention, it was 224. And we all know the importance of visceral fat reduction in reducing the risk of metabolic abnormalities and the CVD risk of CVD. So that is the question to be answered. Should we be targeting the weight loss or fat loss? Should we targeting the waist or weight? So what is there in the pipeline? So we have the interventions for weight loss. Actually, we do not have right now interventions to correct or target the adipocyte distribution or adipocyte dysfunction. So there are different molecules being studied. So broadly, approaches can be categorized into ways that directly target the in systemic inflammation. These are the molecules which are there in the pipeline, and even few of studies have been done and shown some benefit in reducing the systemic inflammation and even in reducing the HbA1c and blood pressure and cholesterol levels. And there are anti-diabetics as well, especially the insulin sensitizers, which address the issue of adipocyte dysfunction actually. So they are already in widespread use. So to summarize, I would say we all know about the importance of body weight, BMI, and it's linked with the morbidity and mortality. On an average, at the population level, there is fair correlation between the BMI and the morbidity and mortality risk. But at the individual levels, considerable variation exists, and that needs to be taken into consideration. That puts the patient at cardiometabolic risk. At the even lower BMI, so there are unhealthy normal weight people actually. So with the more of visceral adiposity at higher risk, so BMI has limitations as a clinical tool to identify overweight and obese individuals who have excess of visceral adipose tissue but normal body weight and normal BMI. So that is a problem with the BMI. And visceral and ectopic fat accumulation and fat dysfunction, which is collectively called adiposopathy, is a major contributor to cardiovascular disease and development of metabolic abnormalities. And this risk is above and beyond the risk due to excess of BMI. There's need to develop simple methods to identify individuals with excess of visceral adiposity or excess of people with adipocyte dysfunction and ectopic fat in clinical practice. And simultaneously, there is need to develop simple and clinically applicable tools which can be useful to monitor changes in visceral adipose tissue and adipocyte function over time. And also, there is need to develop the targeted therapies to address the problem of ectopic fat, visceral fat, and adipocyte dysfunction. That was all from my side. Thank you for patient listening. I hand over to the organizers. Thank you.
Thank you very much, Dr. Arun. Without further ado, let me pass you on now to Dr. Ipsita Mishra. Ipsita, you ready? Please, could you share your screen? You're in silence.
Dr. Mohan is going to speak about the other two cases, ma'am.
Yes. The other two cases are there. I think.
Kindly, Dr. Shenoy, quickly share your screen, please.
Yeah. Yeah. So am I audible? The screen visible?
Yeah. Please
Yeah.
carry on.
Thank you once more. So case 3. So this patient is a child. The child was brought for evaluation of obesity. So the nearing 5 years of age. So he's 4 years, 9 months male child, and he's brought with history of excessive appetite as well. It is actually pre-lockdown. It is actually from last year. So last year, September. So he had come with a history of excessive appetite. And that time he was having progressive weight gain. He was having a weight of 30 kg. And his birth weight was 2.6 kilogram. So immunization records are very important because when that was checked, he was at 1.5 years age, he was 12 kg. So from the last 3.5 years, he has gained the remaining 18 kg. That is fair enough, very good weight gain. And one point to be noted is that the mother says he's very inactive in the toddler period itself. And the question was, there is no history of any long-term medications, no history of lethargy, constipation. The clues towards the other markers, rapid weight gain, other very short duration was not there. It was progressive. No CNS sequelae markers detected. The history, to just highlight, there was a history of developmental delay in the gross motor milestones. The neonatal period also, he was having hypotonia. No history of any visual disturbances, no abdominal pain, no regarding hypothalamic issues, no history of any exposure to radiation. Because of the weight gain, the history of trauma or hip dislocation was asked, that was not there. And family history, significantly, there was history of that is having infertility because the previous 3 deliveries, there was spontaneous abortions, and the lady had taken the couple had taken infertility treatment for many years, for last 1.5 years before getting this child. And family history was significant with diabetes and hypertension, and no history of other episodes like obesity or malignancy or hypothyroidism in the family members. On the measurements, because in the children, we have to measure them very correctly and accurately. In the clinic, we have a stadiometer, and the weight, we have an accurate machine. So the weight, the measurement was, he was actually, presently he was 36 kilograms, and the expected kg for that age was 18 kg. So it's more than the expected. And the height was okay for that because the child has gained weight, so the height will definitely be parallel to that. Head circumference, he was having microcephaly, and mid-arm circumference was more. That was having excess of nutrition. So in this patient, we had an obesity cutoff we had kept because BMI in this child, according to the cutoffs, was given. So for their age and for the weight, so the height, we have the BMI, which is 34.6, which is actually double that of the expected BMI. So seeing the child, it was a very important because the clue was there. There was a low set ears, almond-shaped eyes, lipomastia, because the chest wall also having the fat tissue deposition, and other bony deformities was very important because he was having buried penis as well as the absent left thumb. So the clue was there, and the clinical picture was there, which was neonatal hypertonia. So it's likely to have a Prader-Willi syndrome. We are awaiting the genetic test. So when you classify obesity, Dr. Ipsita will go through in depth. So just to show basically it's a simple obesity, endocrine clues are there, hypothalamic disorders. This patient belongs to the dysmorphic syndromes, and other issues are also there, which are very highlighted. So just to show the syndromes with childhood obesity, the namely syndromes are there, which is actually Alstrom, Bardet-Biedl syndrome. These are all having clues towards that. Our patient belongs to the last one. We are seeing a Prader-Willi syndrome with neonatal hypotonia and having the small hands and feet, and IQ should be assessed for mental retardation. Hypogonadism is definitely there. The clue is definitely the hyperphagia leading to severe childhood obesity. So it's a rare cause of syndromic cause, and it's described in literature by 3 Swiss doctors, and it's actually a paternal imprint disorder, and it's the first recognized disorder related to genomic imprinting in human beings. So other case, this child is 9 years male. This was seen recently. A progressive weight gain was noted of 20 kg over the last 5 years. He was basically brought not just for obesity, he was also having darkish discoloration over the neck. And the mother also mentioned that the child was also having small penis size and breast tissue, that is chest tissue, also having enlargement. And birth history was uneventful. There was no history of any other exposure of drugs or radiation. And the clue to examination, we can see the child was a very chubby child, and there was no other syndromes associated. We can see the axilla and the neck region. We can see severe insulin resistance and acanthosis, and the weight was 50 kilogram for the child of 9 years, and expected was around 30 kilogram as per the charts, and the body mass index was also more than that of expected. So this is the plotting which I have done in the clinic. We can see that this is the very important tool, IAP growth charts, integrating the child's growth, and we can see the BMI growth chart also is there. And you can see that the buried penis, very important to examine the child properly. When we examine with proper precautions, that is using the scale and using the correction for the pubic area, definitely the penile size was normal for that. And laboratory evaluation to complete this, the fasting glucose was abnormal, that is fasting glucose of 120, thyroid function was normal, and dyslipidemia was not there. But you can see that triglyceride level was more for that age, that is 180. And he was definitely shown to have insulin resistance. So HbA1c was shown to have 6.9. So I think I can hand over to the Dr. Ipsita for the taking over for the rest of the talk. Thank you, organizers.
Thank you, Dr. Shenoy. So good evening, everyone. I would like to thank Dr. Roopa and Dr. Abhay sir for the kind introduction. Would also like to thank Sanjay Kalra sir and Gaganpriya ma'am for giving me this opportunity. So Dr. Shenoy has already spoken about two various spectrums of pediatric obesity, which we will be discussing in the subsequent slides. So my agenda for today's presentation will be a very brief review about the neuroendocrine regulation of energy control, the current pediatric obesity definitions and comorbidities, the clinical approach to reach a etiological diagnosis, the various treatment modalities, what is new in treatment, and do we still have a very long way for the treatment modalities. So this is a neuroendocrine regulation of energy control, which is very important to understand the pathology. So it consists of an afferent arm, which conveys the peripheral information on hunger and peripheral metabolism in form of multiple hormonal and neural inputs to the hypothalamus, which contains the central processing unit, which includes a group of neurons that integrates the afferent peripheral signals along with other stimuli and cause an alteration about the neural signals for changes in feeding and energy expenditure. Then comes the efferent arm, which is a complex network of various autonomic effectors that regulate the energy intake and the energy expenditure. So any disruption, whether anatomic, genetic, or metabolic at any of the level of the component, can lead to an alteration in the energy intake and expenditure, causing either obesity or cachexia. Now, what I'm talking here is about the functional leptin resistance and not the genetic one. So this is a limbic triangle which drives the food intake and determines the physical activity in the individual. So most commonly which we deal is the obesity due to overfeeding or overnutrition that leads on to hyperinsulinemia and insulin resistance. And what this causes? Now this causes a state of functional leptin resistance, preventing leptin to perform its normal anaerogenic actions. So from a therapeutic point of view, when we are managing these patients, a reduction in weight and improving the insulin resistance is very important to allow leptin to function normally. So obesity is a significant health problem in children. There are a lot of data. Now, one thing I would like to highlight is 40% of the overweight children continue to have increased weight during adolescence, and 75 to 80% of obese adolescents ultimately become obese adults. So it tracks throughout your entire life food or entire adulthood if not checked at time. So the current definition of obesity is for a child more than or equal to 2 years. If you use a CDC BMI chart and the BMI is more than or equal to 85th percentile but less than 95th percentile, we call them overweight. If the BMI is more than 95th percentile, then we call them as obese. Now, class 2 obesity is also proposed, which indicates a BMI of more than or equal to 120% of the 95th centile or more than or equal to 35 kg per meter square. Another definition is now upcoming but not yet approved, which is called as the class 3 pediatric obesity, where the BMI is more than or equal to 140% of the 95th centile or more than or equal to 40 kg per meter square. Newer term, super obesity, where the BMI is more than or equal to 60 kg per meter square. Now, for a child less than 2 years, we use the weight for the recumbent length, which is more than or equal to 97.7 centile as per the WHO growth standards. So what we use in India is not the CDC chart, but the IAP Khadilkar revised BMI charts, where we start measuring BMI from 5 until 18 years, and until 5 years, we use the WHO growth standards. I'm not going into detail into the risk factors of obesity, but some important predictive factors, that is the rate of change of BMI during and after adolescence, determines the tracking of obesity until adulthood. Very important is the age of adiposity rebound. If it occurs before 5 to 6 years of age, then probably the child is going to remain overweight or obese throughout. Infant overnutrition and parental obesity. Single parent is obese, then probably the child becomes overweight or obese to the tune of around 1.5 to 3 times. Both parents are obese, then probably the child has got the risk of obesity to the tune of more than 5 to 6 folds. So metabolic impact of obesity has already been discussed. So what this causes in a nutshell is when excess fat gets accumulated, then it causes an altered lipid partitioning where fat goes and deposits into abnormal sites. So this leads to an alteration in your adipocytokine milieu, which sets in the insulin resistance and endothelial dysfunction that lays the foundation stone for metabolic syndrome. So apart from this, number of other comorbidities are associated with childhood obesity, some dermatologic findings like acanthosis, hirsutism, endocrine other abnormalities like a premature adrenarche, PCOS, which is very common in an obese adolescent female, other complications like NAFLD, not complications, but comorbidities, NAFLD, gallstone disease, orthopedic problems like Blount's, SCFE, genovarum, valgum deformities. And one important thing which I would like to highlight is the psychological comorbidities is on a high rise, especially in the adolescent population. Severe extreme obesities, also we can find OSA or the obesity hypoventilation syndromes. Renal parameters are also affected. So broadly, the causes of obesity are classified into monogenic syndromic causes, classic endocrine disorders, insulin dynamic disorders, and some miscellaneous aspects. So coming back again, the genetic obesity syndrome, which includes both the monogenic and the syndromic process, are broadly classified into obesity with developmental delay and obesity without developmental delay. Now, amongst all this long list of diseases which we come across commonly is the Prader-Willi syndrome, where these children usually manifest with hypotonia in infancy, failure to thrive, followed by rapid weight gain and hypogonadism. Now, amongst the obesity without developmental delay, the most common cause of monogenic obesity is the MCR4 deficiency, where there is hyperphagia but accelerated linear growth, which goes against the norm of the genetic obesity syndromes, where you get a faltering of the growth velocities. So importance is to identify the clinical hinges and the clinical rings of the certain stigmas associated with these disorders. So classic endocrine disorders includes hypothyroidism, all etiologies causing Cushing's, GHD, and pseudohypopara. Insulin dynamic disorders includes the hypothalamic obesity, which occurs due to either any disruption at the level of the VMH, per se insulin resistance, and the functional reptin resistance. So how do we evaluate these child? History is very important right from the birth rate, the parental BMI, consanguineous marriage, prematurity, GDM, breastfeeding, the age of being overweight or obese, because if it is prior to 3 years of age, then probably we are dealing with a genetic cause of obesity. The dietary pattern, the family history, the family dynamics, the psychosocial history, especially in adolescence, medication history important is the steroids and the anticonvulsant drugs, the amount of physical activity which they perform, and another important crux is the decreased growth velocity against a background of continued weight gain, which gives us a hint towards the endocrine causes. Now, apart the routine history, some other history findings which help us to decide whether we are dealing with a genetic cause or a syndromic cause or an endocrine etiology or certain comorbidities which have already set in, like headache, nausea, vomiting, which talks of pseudotumor cerebri, and this long list of disorders which will give us a hint whether the comorbidities have already set in. Now, in the endocrine causes of obesity, always look for the clinical features of high discriminating indices, whether a symptom or a sign, which will help us to think whether that we are dealing with the endocrine cause. Most important is a faltering of height velocity with a rapid weight gain, along with the particular stigmas which each of these have. So for after a proper history, go on to the examination. So if the child is with you from the beginning, plotting the growth rate of growth in the sex-specific growth charts will help us to for early identification if the child is crossing over the centiles. BMI is the gold standard to assess the body fat till now, which is commonly used. Other methods, the estimation of skin fold thickness, other methods to estimate the body fat or the body fat distribution by waist hip ratio and waist circumference are not routinely followed, and BMI, though it has got many fallacies, still is commonly used. So after the estimation of the oxology or the anthropometry, go on for a detailed head-to-toe examination. Look again for the clinical clinchers of or stigmas of the genetic causes or syndromic causes or the endocrine causes. So as discussed earlier, the stature or the height velocity, features of insulin resistance in form of acanthosis, acne, and importantly, if you're dealing with a syndromic cause, probably the child has got micropenis or undescended testes, and gait abnormalities must be evaluated for. So in short, examine the stature, go for a detailed hint examination, which includes your head, eyes, ears, nose, and throat. Scan for features of insulin resistance or features of steroid excess or hypothyroidism. Abdomen to look at hepatomegaly, musculoskeletal system for gait disorders. Genitourinary system, pubertal staging for the hypogonadism or premature adrenarche if it's exogenous obesity, and importantly, the developmental assessment. Now, apart from this, hypertension or the estimation of blood pressure, which is missed in clinical practice, must be done, and they are labeled as hypertensive if the blood pressure standards are beyond the cutoff values on 3 repeated occasions. So now for children less than 3 years, routine screening is not done, but only under certain specific circumstances like neonatal complications, cardiac malformations, or genetic diseases. Blood pressure must be estimated at least 3 times. So in a nutshell, I would like to tell that suspect monogenic or syndromic causes if you have early onset severe obesity with hyperphagia plus minus developmental delay, hearing visual abnormalities, specific clinical stigmas, most importantly, plus minus short stature, decreased height velocity, plus minus a family history. Suspect endocrine causes if you have short stature, decreased height velocity with clinical features of high discriminating indices. Obesity due to overfeeding or the exogenous obesity, suspect when you have the abnormal dietary habits with a abnormal physical activity, a growth rate which is rather accelerated with or without a parental obesity, and features of insulin resistance. Now, how do we work them up? Now, until 2 years of age, genetic analysis are usually not done if full stigmas are not there. And beyond that, go for the estimation of various comorbidities as mentioned for the glucose values, lipid profiles, LFTs, and ultrasound. Now, bone age estimation is must because in endocrine causes, bone age is delayed, whereas in exogenous causes, it will be advanced. Now, beyond that, fundoscopy, hearing, echo, MRI, hormonal and genetic analysis must be individualized. So, ESG recommends that do not measure insulin in routine evaluation. Evaluate only for endocrine etiologies when the patient is short or the height velocity are decreased. Evaluate for genetics testing only when there is extreme early onset obesity before 5 years with hyperphagia. So this is the total summary. Put the child, classify being overweight or obese, a detailed history, a detailed physical examination, look for comorbidities, classify whether you need an endocrine evaluation, a genetic evaluation, or this is a simple exogenous obesity. Because if it is a genetic evaluation with or without developmental delay, higher investigations like karyotyping, methylation studies, leptin assays needs to be done. So moving on to treatment, what is the treatment goal here? Now, the initial therapeutic goal to treat obesity should be determined taking into account the age, the BMI centile, the pattern of weight progression, and the presence of comorbidities. And we want to achieve a lifelong weight control, which is very important. So along with the weight loss, take care about the growth, height, and the bone health of the child. To look into the comorbidities, establish a good bond with the patient and family, because psychosocial issues are very important. And always keep in mind that the theoretical long-term goal of achieving the expected weight may not be realistic, and avoid yo-yo weight cycling, which is commonly in the adolescence, where there is a phase of weight loss followed by weight gain. So these people have got more cardiovascular risk. So categorize your patient. Increase BMI trend, the percentiles are crossing only a intensive, or not even an intensive, a lifestyle modification with dietary and physical activities will take care of it. Overweight, yes, to take a strict measure on the diet, physical activity, and behavioral restructuring. Now, obesity and severe obesity onwards, intensive therapy of diet, activity, a behavioral therapy, plus minus a need of pharmacotherapy, and a need of bariatric surgery, if maybe for a couple of severe obesity is needed. So this is a common question parents, they ask, what do our child need to eat? So do not give them the diet which is routinely given for adult obese patients. So this is the chart which shows us how to calculate the calories for children up to 3 years and male and females at different ages with different level of activity. Calculate it and divide it depending upon the protein, the fat, and the carb requirement. Follow the principle of balanced diet, a traffic light diet, or the food pyramid. So apart from diet, activity is very important, and the goal of 60 minutes of moderate to vigorous activity in the context of a calorie controlled diet must be followed. Limit the screen time to less than 2 hours, improve the family dynamics, improve the psychosocial comorbidities, especially in an adolescent obese child. So this is a nutshell of how to manage infant with obesity until 2 years. Even though you may be dealing with a genetic cause, you cannot do much of benefit. So right here, take care about the intake, continue to breastfeed exclusively until 6 months, and delay the use of fast foods or desserts. Increase the playtime activity of the child for around 180 minutes, and take care about the sleep pattern. Now, for children with obesity from 5 until 9 years, again, the same process needs to be followed with a pattern of diet, physical activity, behavioral reinforcement. And if they are taking any drugs causing weight gain, then that needs to be taken care of. So what is the target of weight loss? For a child between 2 to 11 years, we want a weight loss target of 1 pound per month. And for adolescents with obesity and comorbidities, we want a target of weight loss of 1 to 2 pounds per month, or which will be realistic, or 2 pounds per week if at all possible. So intensive therapies includes a very low calorie diet, a low carb or a protein sparing modified fast diet, pharmacotherapy, and bariatric surgery. So when the intensive therapy fails to achieve your targets, then pharmacotherapy is advised in certain conditions where the BMI is more than 27 kg per meter square with presence of comorbidities, or BMI more than 30 kg, but the minimum age should be 12 years. And in overweight children, not before 16 years, the drugs must be used. So after, if you use the drugs and you do not achieve to lose weight of more than 4% of the BMI or a BMI Z score by 12 weeks of therapy, then stop the drugs. So there's a long list of drugs, but the only FDA approved drug is Orlistat, which is used more than 12 years, not very effective. Only in 1/3% of the patients who take at least 30 grams of fat diet, it will be probably effective. Now, this is a recent study which was published in NEGM, where liraglutide was used in adolescents from 12 to 18 years, and it did find that lira plus lifestyle therapy led to a significant greater reduction in BMI standard deviation score. Always keep the limitations of pharmacotherapy in mind. The youngest age for which the US FDA has approved the obesity pharmacotherapy is 10 years. Long-term use of these drugs are not proven to be more efficacious than behavioral modification. And only a very small number of trials with these drugs have been done in children. And the relative risk for development of adverse events does exist with any of this drug therapy. So moving on to bariatric surgery. Now we use this in the extreme categories of obesity where the BMI is more than 40 kg or the BMI is more than 35 kg per meter square with extreme comorbidities, and the child must have attained at least an 4 or 5 pubertal development with almost a near normal adult height. and we have failed with the intensive lifestyle modification with or without pharmacotherapy. Now, psychological evaluation of these children must be competent, and they must have the ability to adhere to the principles of healthy dietary and activity habits, and this needs to be done in a center of excellence with a good surgeon. Now, some contraindications are also there. If it is a medically correctable cause of obesity, ongoing substance abuse, or it's adolescent planning pregnancy within 2 years, then the bariatric surgery is contraindicated. Now, this is the data which has been taken from the teen lab surgery. This is a largest study until date, which has taken into the bariatric surgery done in the morbidly obese adolescents. And this data found that almost a large number of comorbidities, there was a reduction in the percentage of the comorbidities 3 years following surgery. Now, this group of children most performed surgery was RYBG and the sleeve gastrectomy. And it was found that both being the sleeve gastrectomy and RYBG, almost they have a similar reduction of BMI on the 3-year follow-up. So now these are the good data regarding bariatric surgery in adolescents. Now, next comes the question of what is the role of bariatric surgery in special populations, especially those who are having syndromic obesity or the pre-adolescent children or the hypothalamic obesity categories. Now, some series have given promising results in all these 3 groups of children, but yet we cannot implement onto larger population until and unless we have large randomized trials. So the future therapies are now arising with these drugs like topiramate, phentermine, and lorcasenin, which are approved for use in adult obesity, which act as by the anaerobogenic pathway, and oxyntomodulin, which is the peptide YY analog, which causes inhibition of the neuropeptide Y at the level of hypothalamus. So some trials with these drugs are going on, and in future, maybe we get the results of these trials. Another newer therapy is the use of an implantable pacemaker, which signals the brain that the stomach is full, is also in trials in some smaller populations. So we can expect answers in the future. So to summarize, I would like to say that pediatric obesity has its basic in genetic susceptibilities, influenced by a permissive environment starting right in utero and extending throughout childhood and adolescence. So always remember the principle of Barker's hypothesis. Endocrine etiologies for obesity are rare, and they are accompanied by attenuation of the growth patterns. Genetic screening for rare syndromes is only and only indicated in presence of specific history or physical features, and again, these are very rare. Pediatric comorbidities are very common, and screening for comorbidities should be done in a very hierarchical, logical manner, and they need to be taken care of. Most important is one factor, which is the psychological aspect, which needs very important and needs to be taken care of, not only of the patient, but also the parents. Prevention should be the primary goal, because how much ever you try, once overweight and obesity sets in, it's very difficult to revert them back to normalcy. Use of any drugs as a treatment for pediatric obesity should only be restricted, and should be done by experienced physicians or in some clinical trials. And now we are getting evidence of effectiveness of bariatric surgery, especially in the mostly severely affected mature teenagers who have failed lifestyle modification. But again, the use of surgery requires experienced team with resources for long-term follow-up. Thank you very much for your patient hearing. I would like to hand over the session to the organizers, please. Thank you.
Thank you very much, Dr. Ipsita. So we've had 3 excellent presentations. You can stop sharing your screen, Dr. Ipsita.
Yeah, sure. Yeah.
So we've had some excellent case histories from Dr. Mohan. And also then we started with Dr. Arun, and he talked to us about the varying concepts of the metabolic syndrome, the role of visceral fat and how damaging this can be with respect to inflammation and provoking the complications. And then he went on to the complications and the management of complications. I think one interesting raised was the limitations of body mass index when we evaluate risk these patients. Should we be using body mass index? Should we be really concentrating on waist circumference? What is the best measure? And then we had an excellent presentation by Dr. Ipsita about childhood obesity. And here again, she went into the monogenic, endocrine, and the exogenous causes. She talked about the importance of the clinical examination, and that under the age of 3 years, we should really be looking at monogenic possibilities. But I think one of the most important aspects that she mentioned was this management of exogenous obesity. This is increasing worldwide. And I think her last slides where she talked about what we can do as a preventive strategy for our children is very important. So I think I'll leave it there with respect to the summary, and I'll hand over to Dr. Abe so he can go into the quiz questions and any possible questions and answers.
Yeah.
Thank you.
Thank you, ma'am. And thank you. It's a nice, beautiful presentation by all our speakers. And again, beautiful case presentations by Dr. Mohan. And before going to our question answer session, first of all, we'll discuss about the quiz questions which has been given. Actually, there are 5 people who have been actually selected for today's quiz, or the fastest finger first. It is Dr. Dhanpal Mankapure from Miraj is number 1. Dr. Anwar from Katak is number 2. Dr. Manish Kumar Jingan from Satara is number 3. Dr. Unikrishnan from Kochi is number 4. And Dr. Indrani from Chennai is number 5. So these are the 5 people who have qualified. Actually, Dr. Mohan, you have really actually increased the quality of questions too high, so it's a bit difficult for everyone. Okay, but still, I will appreciate everybody's response and everybody's effort who has put that much effort to make these questions. And important is that all those people have answered all questions right. So this is the important thing. Okay, fine. So we have few questions. First, to Dr. Arun, what is the actual pathology of obesity going to make syndrome X or insulin resistance in type 2 diabetic patients? So first we will discuss what about the questions we have got from our audience. Then if we'll have some time, then again we'll discuss among ourselves. But this is the thing. What is the actual pathology? What you are thinking, Arun? What you are thinking that for the syndrome X or obesity point of view in type 2 diabetes, what is the actual thing which plays a critical role?
So yes, so I think the question is what leads the fat cells or adiposity to cause the insulin resistance and then the metabolic abnormalities. So definitely the etiology is not say unifactorial, it's multifactorial, and I had a couple of slides on that showing the molecular pathways which are believed to lead to the systemic inflammation and insulin resistance. So definitely there must be some component of genetic susceptibility also. It's not only environmental causes. So genetically predisposed people with excess of calorie intake, sedentary lifestyle, that all leads to the fat deposition in ectopic tissues and visceral tissues, which are actually not supposed to store the fat tissues. It's fat deposition at ectopic sites, and excess of fat at these sites lead to the altered intracellular pathways, upregulation of pro-inflammatory pathways, activation of nuclear factor kappa pathway, release of interleukin 6, TNF-alpha, and all these factors. So it's multifactorial. There's no single inciting or factor that is known to cause all the problems. There are multiple
thank you. Actually, this is the thing. This is the thing that there are multiple factors which plays a critical role for particularly making syndrome X. It's not a single factor which is responsible, or to tell that this is the only one factor which is important for particularly making the person obese from normal or from a diabetic to make a person specifically to metabolic X or syndrome X. Dr. Ipsita,
Yes, sir.
could you please think what in your opinion you have actually started your MBBS 10-15 years back. In your 15 years career, how you will tell that what is childhood obesity, how it has increased? And regarding one of our friend has asked that regarding the lorcaserin use, how in how many patients you have used lorcaserin again? Why it has been actually banned so early? Within few months of starting. Most probably it was banned. So
Yes,
why it
sir.
was banned?
So I would like to take up the first question where you asked have the IUGR children are there and the body tries to defend. They are hyperinsulinemic right from the birth, and once they come out, they catch on the weight and the right they set up into insulin resistance and increase weight gain. So this epigenetic modulation is very important, which determines whether the childhood obesity will set in or it will not set in. So the second question I would like, and along with this, there are other multiple environmental factors: diet, physical activity, exercise, exposure to some endocrine disruptors, which we do not routinely do, but maybe in the Western countries, they look about that part and evaluate for the endocrine disruptors also. Now, the concept of gut microbiome also is arising as a risk factor of causing the epigenetic modulation. Moving on to your next question, yes, lorcaserin was had come into the yes, sir. Lorcaserin had come into the market, but it was very soon it was banned from the market, and it was withdrawn because of there was a potential risk of increased malignancies, which was studied for which lorcaserin was withdrawn from the market.
Thank you, Ipsita. And I would request Roopa ma'am, Dr. Roopa, what is in Mexico, how much childhood obesity you are getting, and how you are, what is your approach there, and how you are usually deal with those childhood obesity patients?
So I think Mexico now is #1 in childhood obesity in the world. So we have similar problems to what Dr. Ipsita was mentioning. Most of this is exogenous obesity. This is because of processed foods, endocrine disruptors, sedentary lifestyle, and this is very difficult to actually change. I mean, you mentioned the management issues, and we try and do this, but it's very difficult. It's education, not only in the family environment, but also we need public health policies to kind of help in this process. For example, around schools, there is a big sale of these unhealthy foods and snacks, and I think it's the same in India. And we're still having challenges to ban these kind of products for children. So there is still a lot to do, but I think between India and Mexico, very similar problems and health issues.
Yeah, in looking you, I thought there will be no obesity in Mexico. So that is the thing. So, Mohan,
Dr. Abe, you're just looking from the head up. You haven't seen the bird.
Mohan,
yes, sir.
Tell what is the status of obesity in lean diabetic patients? What is your opinion?
Yeah. So what the question was regarding the low BMI, as that is obesity in low BMI. So this is not because of we should not look at numbers in that case. BMI, there is also something called waist hip ratio, because visceral obesity is very high, because as you know, when patient is also coming to you, I had shown you the case that is showing the metabolic markers were not there in that patient, but you can see that waist hip ratio is high. That is itself can lead to lipotoxicity. Free fatty acids can be liberated and fatty liver can happen. So now what we are suggesting is that it is a person-centered obesity care. because when patient comes to us, we have to have the secured model with us, because it's a code developed by Dr. Nitin Kapoor and Dr. Sanjay Kalra sir. It was published in editorial. I'll just highlight the main points in that in 2 minutes. Secured stands for, S stands for severity of obesity, that is the BMI and the waist circumference. E stands for the prognosis, that is the expected lifespan of that person. The child is young, he's expected, or he or she is expected to go a long duration. So lifespan is important. C stands for the comorbidities, that is the metabolic, mechanical, and mood disturbances. U means the urgency of control. How biomedical and psychosocial issues can require early weight control. R stands for the risk of complications like malnutrition, as you had shown, gallstones, other. I think this life immensely. So I would request all of you in the audience to go through that model, secured model, because it's a person-centered obesity care.
Yeah, thank you, Mohan. And Dr. Roopa, could you please highlight about something about ketogenic diet? What is your opinion about ketogenic diet? Again, what is your opinion? A lot of the time we are going, a lot of people are going for intermittent fasting. So what is your opinion regarding that part related to obesity?
So ketogenic diets do work with respect to weight loss. Patients will lose weight. However, it's not a diet that can be maintained for a long period of time. So as soon as they leave the diet, the actual regain of weight is even worse than the initial overweight that they already had. So I don't recommend this to my patients at all, even though many people do follow these ketogenic diets. Also, the complications of ketogenic diet. We did this in a small group in my center, and obviously this increases LDL cholesterol as well. I think, I don't know, of you, is this happening in India as well?
And Dr. Arun, could you please throw some light about intermittent fasting? What is your plan? What is your thought process about intermittent fasting? Dr. Arun?
So yes, so I had that slide, and that counted just only few of the diets which are there, popular ways to lose the weight. So it's not any particular type of diet which decides the long-term outcomes. Actually, it's the adherence and persistence to the any given diet. And as the time passes with the weight loss, actually the resting energy expenditure goes down as an adaptive phenomena that happens at the central level, and the rate of weight loss goes actually low. So that because of that, many people get discouraged with the slow weight loss after some time, and they discontinue with the ongoing treatment or dietary intervention actually. Then over the long run, none of any particular diet is superior, and definitely we need to have into consideration the macronutrient and micronutrient composition. So we need to consider the safety of these interventions as well, and rightly pointed out Dr. Roopa that in terms of ketogenic diet, there is a risk of dyslipidemia, and that could be detrimental. So that is particular about ketogenic diet, but I think intermittent fasting, we do not have any of those risks involved here, except for the people with over diabetes and who are on sulfonylurea or insulin. Again, that group may be predisposed to the hypoglycemia.
Yeah, make it
I would like to interrupt here a little bit, sir. There was a paper which was published in NEGM regarding intermittent fasting. So intermittent fasting has got various protocols, and it has clearly mentioned that it is now being found to increase the longevity, decrease the CV risk, decrease the metabolic risk, and decrease the cancer. And this is being followed in one of the particular villages in Japan. I think it's Osaka or some village, where they're finding that the longevity of the average person is more than 90 years. So that was a paper which was recently published in NEGM, where they did find that intermittent fasting is beneficial to increase longevity and decrease the cancer risks.
And Ipsita,
Yes,
another question to you, that when you think about childhood obesity, whether total calorie intake is important or the food pattern or the composition food is important, like whatever, how much fat you are taking, how much protein you are taking, how much carb you are taking, that is important, or total calorie intake?
Sir, both are important. Both are important, sir. When we want to achieve a weight loss, then we have to balance the calorie intake, and also we have to add a look on at the expenses of the calorie also. So both needs to be balanced. And when we calculate the calorie depending upon the weight of the child and depending upon the level of activity of the child, there is a rough calculation of around 35 kilocalories per kg. And if the child is sedentary, then you add 15 kilocalories per kg extra. Or if the child is doing vigorous activity, you add up to 60 to 65 kilocalories per extra. Now, when you calculate the entire calorie content, then again you have to subgroup to the food pattern. Now, in pediatric obesity, no particular hypocaloric diet is specifically followed. So again, from that, you divide to the carbohydrates content of around 40 to 45, a protein content of around 15 to 20%, and a fat content of 20 to 35%.
Make it crisp.
Yeah. So
Thank you. Mohan, tell me one thing. That for obesity, what are the inflammatory markers you do for the clinic, for a clinician to do that these are the inflammatory markers? If I am doing, at least I can tell the patient is a metabolically healthy obesity or metabolically unhealthy obesity, or this person has more risk of cardiovascular complication in future.
see, this is a point because it's a research molecules are developing, and I think with the available molecules we have, I think uric acid is a good marker for obesity and metabolic syndrome. But there are many fallacies because the diet will be wrong. Maybe the technique of testing also may be wrong. It's not reliable in that setup for everyone. But there is a recent publication in Calcutta which has highlighted that our population also has inherently a high tendency for metabolic syndrome with uric acid levels. Then the other markers like HSCRP are just out of the fashion now. They are not very much followed. The most important marker is the cholesterol, that is the total cholesterol, HDL and the LDL. These are the three are very easily made out. And I think for research purposes, adiponectin is the marker which is found to have a cardiovascular mortality. I had a question on this, so that was the answer for that because it was inverse association with the cardiac risk. The lower the value, the higher the risk. And there are many outcome studies on this also. So their investigational research is still on. I think we have to wait for the results to be out. I think Dr. Roopa will be having idea because I think they're happening most often from the.
Beautiful. Actually, Dr. Roopa, what sort of investigation again you are doing there for regarding this obesity point of view for additional investigations? What Dr. Mohan has told.
We're also looking into intermittent fasting. So we have. We're carrying out studies in both obese population and diabetic population, looking at the various regimens and the possible benefits. So even doing clamp studies in these patients. So I think some interesting work will come out of that. Also with lipids, my direct boss is a great expert in lipidology. So we have various studies looking into genetic alterations, even the common variants that can be associated maybe with hypertriglyceridemia and other lipid profiles. But more than anything, I think it's just a general look at various at-risk populations that we're doing in our center. I think what Ipsita said about fasting, it is becoming more popular, but we need to know which regimen is the best and in which kind of patient. This may not be applicable to all patients. So I think this will be a very important result.
Yeah, thank you, Dr. Roopa. And Dr. Arun, a final word from your side. What is the difference between adiposopathy and adiposity or obesity in common word? Because a lot of the people still get confused with the word adiposopathy. So what is a final? Give a final word to all our friends. What is adiposopathy? How it is differing from adiposity or from the particularly specifically obesity point of view? Arun, please.
I think you're muted.
You're muted, Dr. Hanuman.
Yeah.
It's very simple concept, sir. So we have seen the excess of body weight is associated with the adverse outcomes, increased morbidity and mortality. The most commonly used parameter to measure the body weight has been BMI, body mass index, but that does not consider the body composition, the distribution of body fat or protein, lean body mass. So that is the limitation of body mass index. So obesity, by definition, actually should be the body fat composition and the amount of fat in the body. So that is adiposity, excess of fat tissue is the adiposity, and adiposopathy is the disorder of adipose tissue, which is caused by excess of fat and at abnormal sites, and that leads to the dysfunction of adipose tissue, adipose sites. So abnormal structure or function of adipose tissue because of excess accumulation at abnormal sites, causing the metabolic abnormalities and increasing the cardiovascular risk. That is the adiposopathy. So
thank you. Excellent. And Dr. Ipsita, a final word from your side. What sort of advice you are going to give for childhood obesity? Because we know everybody wants advice. Everybody in everybody's house there should be obese child. Most probably now the situation is like that in India also. So what sort of advice you to give all our friends?
Prevention is the best advice. Right
So
from
what,
birth. So right from birth, start giving them breastfeeding, delay weaning diets at least till 6 months. Do not introduce sugar-containing diets, frank sugars, which almost all the Indian mothers, they start doing by 3.5 to 4 months of age. The mother is obese, the mother gets happiness in feeding the child. And one simple line I would like to say, sir, which was mentioned in Sperling textbook, which I really liked it, quote unquote, food is not love and love is not food. So that thing should be taken care of by the entire family and improve the family dietary habits, because children follow the pattern of the family. So right from the beginning, take care of that part.
Okay. And Mohan.
Yes, sir.
And regarding the specifically the syndromic diagnosis.
Yeah.
How frequently you get this syndromic obese people, and what is the initial approach? When you just suspect a syndromic obese child in your clinical practice?
Yeah, so this is the point, because syndromic obesity is not common. Unless we suspect, we will not identify it. And because I was from pediatric side, I have come from pediatric side. So I have been tuned to seeing the child with obesity and the syndromic side. So from that angle, I may have advantage because I have clinical exposure to them. But a physician also, when a child comes to the physician after some time with the obesity, then there are many clues and pointers like low set ears, like as I told you, very unique bony markers are there. And I think bone age also is a helpful index, because when you have a child gaining weight, and the bone age is also important, because endocrine causes can be suspected by bone age, which is actually delayed. And hypothyroid is one of the reasons for that. And yeah. And other outcomes are very there, because genetic tests are not done very routinely, because we cannot have them done for our lab, because we cannot send this patient has been evaluated because suggested to have genetic testing, because in future he may require growth hormone therapy. That is one option for him, because when his body fat is not proper, the final height may not be also attained. So for that angle, we have to consider genetic testing in Prader-Willi syndrome, because OSA, many things can happen in the long run, which we can do by proper genetic, because the future generation also has to be dealt.
Yeah, thank you. And Dr. Roopa, this is the final word from your side. Mohan has presented 3 cases. According to you, what is the best case, or what is the best thing what you are finding in Mohan's case? Dr. Roopa, please.
That's very hard. I think I specifically liked the Prader-Willi case. I think This was very nicely presented, and you showed all the features very easily. And you showed us how important it was to look at the history in the family, the history of the child, their development, and also the clinical examination of the undescended testes and all of this, because we may commonly not look at this. So I think that was, for me, the most interesting case.
Yeah, actually, that responsibility was given to me, but it was very difficult for me also to choose what is the best case. So I thought let Dr. Roopa should help me out what is the best case. So most of that Prevalence is the best case.
Excellent cases. But,
Yeah,
but
that is the best case what we have discussed now. So with this much, I am handing over the session to the to Renu and the Torrent people. So for the final vote of the thanks.
Thank you.
Thank you.
Thank you, sir.
Thank you, sir. Is Amit around there? I think we had the results. Any clue about that, Amit?
Can you stop?
Yes. You want me to show that?
Yeah, yeah.
Yeah, that is, yeah.
Yeah.
Okay.
Yeah, regarding the quiz, I think we had this questions. So just discussing the questions regarding the quiz. The first answer is regarding J-shaped, because as Dr. Arun had shown, J-shaped is the one which is the chronic disease. I think majority have not answered it, but you can see that some are answered. The regarding cytokine, adipocytokine causing inverse causality, as I had told you, adiponectin is the answer. And again, I think the C was the one chosen, but that is not. I think the quiz should have reflection of the complex and the nature of the obesity we are seeing in the population.
But still, beautiful question,
Thank
and
you, sir.
we have also learned a lot from this actually question and answer session. And thank you, everyone. And at the end, I will hand over the session to Renu and the other people for the vote of the thanks.
Thank you very much.
Thank you. Thank you.
They are not there, I think. Huh?
So, ma'am, will you just summarize? Yeah, I don't think anyone else is there.
So I think we've had 3 excellent presentations. I hope they've helped you understand the aspects of the metabolic syndrome regarding the management of childhood obesity, and then the presentation of 4 cases that we may commonly find in our clinical practice. I would like to thank everyone for participating. I think we are now finishing. We're quite short of time. We had many questions, and I hope as well the quiz, you learned from the questions in the quiz as well. I'd like to thank all the speakers, Dr. Mohan, Dr. Ipsita, Dr. Arun, and of course, Dr. Abe for being our moderator. And of course,